So today I wanted to play some city skylines and talk about healthcare systems and the kinds of policies that allow a population to be healthy. Something about creating a society in city skylines makes me feel, one, all-powerful, but two, responsible for the types of lives that its people lead. I guess part of creating the infrastructure makes me think, I'm sure it's made you think, how can we improve on our current city, whether that's fixing traffic blockages or optimizing subway locations? Is there a better way to do what we're doing now? From a top-down perspective, like in this game, where you get to set zones and decide locations of cities or suburbs or transportation methods, you really think about the impact of the societal framework you've built and the effect it has on the people living in it. And just like in real life, you have to work within the constraints of a budget, unless you're playing sandbox mode or maybe like the United States, willing to spend more than their revenue and worry about it later. But actually, I think the real story starts here. This is Steve. Given the conditions of the city I've set up for him, I can determine how long he lives. If you graph life expectancy at birth versus healthcare spending per capita, almost every country falls along this curved distribution, where generally the more you spend on healthcare, the better your citizens' life expectancy, except the United States. We'll talk about that later. Regardless of who you are, what you do, what you eat, how much you exercise, this is, on average, depending on where you live, how many years we get. This life expectancy, this is us. And so this video really centers around one question. How can we make healthcare better? To start off, no one's cracked the puzzle of how to make a perfect system where incentives are best aligned with the health of the people. We're going to look at different types of healthcare systems around the world now and what people have already tried, their advantages, incentives, and trade-offs. Number one, the out-of-pocket model, also called fee-for-service. I think it's the easiest to understand. You pay the money, you get the service. Steve walks into a clinic. The doctor, Abraham, says you're sick because of condition A. He can fix it for $50. Steve says great and pays up for treatment. If Steve can't pay, well, tough for Steve. Just like you buy any other item at the supermarket, in this case, you buy good health. So why don't we all use this? It seems pretty easy and convenient. Well, as we discuss each system, we can think of who has the power in this dynamic. In this situation, the doctor has every incentive to push as many procedures as he can because it's his direct source of income. Who sets prices for things? Dr. Abraham does. There's an information inequality between what Dr. Abraham knows and what Steve knows. Steve, you have a unique case of condition B. I recommend doing this complicated procedure and it's going to cost you $3 billion. Just swipe your card here. Steve says, I can't afford that. Well, tough for Steve. Now, I'm not saying the doctor is out to get you, but in this fee-for-service payment model, he's incentivized to get you to pay as much as possible. For background comparison, most developed industrialized countries have established healthcare systems for mass medical care, so they don't use the out-of-pocket model. Most countries in unindustrialized nations do use the out-of-pocket model, which is the majority of the world. Number two, the Beveridge model, also called Nationalized healthcare model. This is the model that most closely resembles what we have in city skylines. Here, the government controls most healthcare institutions, and most doctors are government employees. That is to say, if I were the government, then I would own this hospital. I pay for all its costs and employees. Beverly never has to see a medical bill because I pay for it through taxes that I collect from her. For the most part, I get to control costs because I determine what procedures I will fund. So, for example, if I want to fund complicated and expensive procedures, then I'll have to raise higher taxes to pay for them. Conversely, I can decide to not fund them if I feel that taxes are too high. You can sort of tell that the societies who choose these types of models made a decision about what its citizens should have and then created policy to suit the idea. So what are disadvantages of the Beveridge system? Well, since funding is tax-based, the government has incentive to fund the highest health return on investment, right? I want the healthiest people while paying the least I can. Primary care has a super high health return rate on investment, so I want to have a lot of that. In fact, most of these hospitals you see in my district will be primary care. Everyone has a limited budget, so in this case, specialized care is harder to access, or maybe they have extremely long wait times. I as the government, won't want to spend money on new technologies, and the doctors get paid much less than they do in America since I'm paying them a fixed salary. So who has the power in this relationship? The government, do. I dictate what doctors get paid, what procedures are approved for funding, and what kind of care people can access unless they want to pay out of pocket. Some countries that use this model include Britain, Italy, Spain, Scandinavian countries, and New Zealand. Number 3, the Bismarck Model. In this model, these hospitals are privately run and the doctors are not on my payroll. Brittany and the company she works both pay into an insurance system. The system covers everyone, and by everyone I mean citizens. Good luck, Steve. The system is non-profit, which is different from the US. Germany, Switzerland, Netherlands, Japan, and other countries use the Bismarck model. Again, the government chooses which services are covered, so I can have a lot of the cost control measures as before with the Beveridge model. Last, we're going to talk about number 4, National Health Insurance Model, also known as the single-payer system, sort of a combined Beveridge and Bismarck model. Countries using it include Canada, South Korea, Thailand. The government, regulates which programs and services to fund, and everyone pays into the system. Natalie gives me health money, and I decide how to spend it. Because I am the sole purchaser of services, I can negotiate low prices from pharmaceutical companies. So if, Cocoa Donuts can give me a better price per person for donut pills, then they get every single Cocoa Donut pill order in my country. Obviously, I can control costs by limiting services that patients get treated for. So on the flip side, because of, I'm limited by how much money I have, so the budget allocation on certain services, other services won't get covered. So for example, I can decide that I just won't cover eye surgery, or maybe I'll only cover the cost for one spot per year. Steve can either wait like a billion years or pay for it himself. At this point, you're thinking, okay, great, but which one is the United States? Well, it actually has parts of all of these systems. For the elderly, poor, and disabled, the United States provides Medicare and Medicaid. People who can afford private insurance are on the Bismarck model. People without insurance are in the out-of-pocket model. And we have veterans and Native Americans on the national health system, like the UK, where the government owns and pays providers. It has enough issues in execution that we won't discuss it here. The US also uses a reimbursement system where instead of direct payment, hospital or doctors or administrative staff argue with insurance companies on how much your care should cost. The health insurance plans assume risks that occur across the people it covers, and that's why you may have issues coming up with certain plans not wanting high-risk patients because they cost more. We have long lives now, and that's a huge win on the part of modern medicine. But with our longer lives also comes problems. As a doctor once said to me, cancer is not an if, it's a when. And right now, our healthcare system in the US is just not equipped to deal with financially an aging population. So what can we do? 1, we can throw money at the problem until it goes away. That will work up to the point where we realize, hey, we're spending so much on healthcare and we're not on par with other countries. 2, we can try to make our current system better by eliminating inefficiencies or optimizing health output. The reality is that everyone from the top down is looking at the same complicated monster that is our healthcare system, with its inefficiencies and pharmaceutical costs and secondary care procedures and reimbursement, and we have no idea. Changing any part of the current system means taking money away from someone who is benefiting from the current status quo financially. That's why change is so hard, because financial advantages can translate to political pressure in the US. So here's an open thought experiment to anyone who likes playing City Skylines, because you know what it's like to have the power to decide everything, the lack of political opposition to your decisions, and the kind of optimism it takes to shape a city in your image. What kinds of policies can you set in place to be best aligned with the health of a society?